my talk is on cataract with lamellar macular hole, not a very common kind of, I would say, among all the retina problems. Macular hole, which is much more common, or the other conditions which other speakers are going to talk about. But the point is that whenever we have a patient, we look at the patient as a whole. That will be the topmost message it will come out. But otherwise, after that, what happens is mainly for retina surgeons. I think cataract surgeons don't have much to do with the lamellar hole other than refer or work as a team. So, a lamellar macular hole is not a full thickness macular hole which we all know about, but it's the inner layers of the retina which are thinned out. There's still some external retina which is still remaining, and it can be associated with ERM or lamellar hole epithelial proliferation or LHEP, and it may have an undermining of the edges usually, or it may have other problems associated with it like disruption of the ellipsoid zone and the ELF. There are two types, one is the tractional type and the other is the degenerative type. The degenerative type is more common in normal circumstances when you see. The tractional type can be seen in high myopes as well. It can be seen in the MTM classification also. But when someone is faced with a cataract and a lamellar macular hole, the point here is you must consult a retina specialist who will work as a team with the cataract surgeon. Don't just, the best way is to be with the patient together, at least call up the patient. One of the less acceptable form is just send the patient and not know what is being done to the patient by the retina surgeon. But at least it's still better than not sending to a retina specialist also. But what will happen is the retina surgeon will also evaluate the retina along with the cataract, and we can come to a conclusion or communication with the patient as to how much is the improvement going to be after cataract surgery. This is the biggest dilemma that cataract surgeons may face, because we all know in retina specialty we don't give 20/20. Retina surgeons are not 20/27, but we at least maintain the vision in progressive chronic disease. We don't let them go blind. But instead of telling a patient you have cataract, operate, and then patient is unhappy, then we have to not just manage the patient's expectation but the cataract surgeon's expectations also. Instead of that, let's work as a team. So what could be the different scenarios which may come up? Some lamellar holes actually may not need a surgery. They are usually associated if the outer segment photoreceptors are good. They do get good surgery. So that becomes like a pure cataract surgery. Cataract is significant, go ahead and do the surgery. But if there is an issue, whether a retina surgeon decides that you have to do retina surgery vitrectomy, then the dilemma comes. What kind of practice do you have? Is it sequential? Should I do cataract surgery first, then go for vitrectomy, or the other way around, or is it a combined? But either way, the communication has to be done and avoid the VIP syndrome. Whatever happens, generally, if a patient comes, typically we tend to do our stuff first and then to not communicate anything to the patient or the other specialty doctor also. I will do my job and then we will see and send that patient if there is an issue later on. Let's work as a team. So in this case, there are two cases that I am going to present. One is a degenerative form, one is a tractional form of lamellar hole, which I had mentioned. A patient from Nagpur was actually referred here to us, and he had 20/100 vision in the right eye. As you can see, in the OCT, you can see the degenerative type of lamellar hole with the photoreceptor or the outer retina more or less intact. And based on this, we can actually communicate with the patient that your visual recovery is going to be likely to be substantial. There are cases where 20/100 may remain only 20/100 also after surgery. That will tell that this is to prevent further vision loss. But in this case, it is likely that this patient is going to improve further. So in this patient, we took up the patient for surgery with ILM peeling, which is foveal sparing. And I'll come to some article on publication on that. That patients in lamellar hole, you should peel the ILM, but you should not do a complete peel. You should spare the fovea because they can have other complications. So the routine PVD induction and careful, it's a hyaloid vitreoschisis which is usually there. That's why these patients have the degenerative. You see a careful transition staining, then brilliant blue staining. And when I'm peeling the ILM, it will be spared over the center of the fovea. And with a scraper or a finesse loop, you can gently push it over. And this is what the post-operative OCT is. In this patient's vision is 20/25. You can see that the undermined edges of the lamellar hole which was there, it has become more or less a normal contour now. This another patient where we did cataract surgery along with lamellar hole surgery with ILM peeling and foveal sparing, and along with that I had to inject Ozurdex because this patient had significant edema during the, before the surgery was done. So this patient improved significantly. As you can see, there was edema, it was settling down later on, and at 1 month the vision was 20/30. And this was one of the articles which I was alluding to earlier, that in patients with lamellar macular hole, if you do a conventional ILM peeling versus an LHEP embedding, that is, you invert it and embed it within the so-called hole, partial hole, those patients have better visual outcome, and the macular hole formation is significantly lower. In LHEP embedding it was 0, whereas in the other patient it was more than 10% case at full thickness macular hole development later on post-operative. So I'm just going to conclude here that lamellar holes are slowly progressive, if at all. Here the symptoms are also given to important metamorphosia. Cataract surgery can be performed as stage or simultaneously depending on the grade of cataract and the surgeon's preference. And teamwork is extremely important. Thank you all very much for your attention.